there, everybody. Welcome to the Cambridge Festival. Thank you for joining us here tonight at the Cambridge Union. Would you like to give a round of applause to our first panel, and we'll see if we can fix the NHS and social care.
Right, thank you everyone. I'm chairing today. I'm Hilary Cooper. I'm now a writer and researcher on social policy issues, having previously spent my main career in the civil service as a government economist and policy advisor in both national and regional government. So welcome to this evening's panel discussion on the very pertinent and timely subject of how we fix the NHS and social care. We've got a fantastic panel to debate this and to respond to your questions, and I'll introduce them shortly. First, though, a little bit of scene setting. We know from political polling that the NHS is now the top priority as we go into the next election, overtaking even the cost of living crisis in voters' concerns. Satisfaction with the NHS is plummeting, and we see the consequences of the crisis the NHS is facing in waiting lists that have gone up from 4 million before the pandemic to 7.8 million now. We see it in the well-publicised problems with ambulance waiting times, and outside of hospital provision, we see an overall worsening of general population health. So there are 2.8 million people of working age who are long-term sick and not able to work, and that's gone up from 2 million in 2019. Many people who are in work but waiting for treatment cannot work to their full potential, and these challenges now include significant rises in mental health issues alongside physical health. We also have very many people who are in work and have caring responsibilities who are struggling to reconcile the two pressures because they lack the support that they need. All of this has huge personal costs, but it also has economic costs in lost output, in low productivity, as well as in increased payment of sickness and other benefits. And at a time of such lackluster economic performance, we really need to get a grip on these issues. Independent research that's been published in the last few months shows that if you set ourselves against comparator countries, the austerity years led to lower funding and investment per head of the population, with the consequence that we now have fewer beds, fewer scanners, fewer doctors and nurses, and higher avoidable mortality rates than our peers do. The headwinds are problematic. We have an ageing and a sicker population. We have rising health inequalities and long-standing problems recruiting staff into the NHS and into social care. So it's no surprise then that all the main political parties are prioritising fixing the crisis. Jeremy Hunt's recent budget allocated a funding pot to deal with short-term pressures like waiting lists, and Labour have announced measures to do the same. Both parties are highlighting potential productivity improvements as one way forward, and the budget announced £3.5 billion for digital healthcare and new IT, while Wes Streeting, the Shadow Health Secretary, has foregrounded productivity-enhancing reforms to NHS practices. Labour's planned labour market reforms include a proposed fair pay agreement for care workers to support recruitment and progression, and Labour is also signalling that they want to prioritise primary care and prevention, so community provision, pharmacies, GP services, even NHS dentistry, to improve population health at source in the hope that this might stem the rise in preventable illness and stem the rise in hospital admissions. It's an enormous agenda. The problems are deep-rooted and solutions are clearly needed. So with that scene-setting overview, I'd now like to turn to introduce our panel and invite them to speak for around 5 to 10 minutes each before we open up to questions from the audience. So the first panel member I'll invite to speak is Professor Mike Kelly on my right. Mike is a senior visiting fellow in the Department of Public Health and Primary Care here at Cambridge University. He's previously been the director of the Centre for Public Health at NICE, and prior to that worked for the World Health Organization's Commission on the Social Determinants of Health. He's advised the House of Commons Health Select Committee and is frequently a witness before parliamentary committees. After Mike, we'll hear from Thara, who's the Director of Population Health and Inequalities at Warrington and Halton Teaching Hospitals, and she was previously Director of Public Health for Warrington Borough Council, in which capacity she oversaw their public health response to COVID-19. Next will be Geoff Wong, on my left, who studied medicine here in Cambridge at Robinson College before training as a GP. He's currently Associate Professor of Primary Care at the University of Oxford, where he applies realist research approaches to make sense of complex interventions. And he still works as a GP, having spent 30 years in the NHS. Our fourth speaker is Emily Kenway, a writer, researcher, a former carer who writes and speaks on social issues. She's previously been shortlisted for the Alpine Writing Fellowship and nominated for a Pushcart Prize. Her second book, Who Cares? The Hidden Crisis of Care and How We Solve It, was a finalist in last year's Orwell Prize for Political Writing. So just to refresh on how we're managing the evening, each of our panel will speak, then I'll ask some questions, and then we'll come to the audience. The event is being live streamed, so we have an online audience, but all the questions will be taken from the in-house audience. So yes, Mike, over to you to kick off.
Thank you, Hilary, and good evening, everybody. A great pleasure to be here, and really nice to see you all joining us. Now, I've got about 5 important things I want to say to you. The first of which is what I don't want to happen in order to try and fix the NHS and social care. And my first principle then is the last thing we need is another major reorganisation. We had reorganisations under Alan Milburn when the Blair administration came in. We had a massive reorganisation after 2010. And the problem, as I think you will all recognise, is that reorganisations don't come at no cost. There are enormous transaction costs, first of all. That is to say, the whole business of changing things round. And whether it's the minutiae of changing the names of offices and buildings and that sort of thing, changing the logos on office paper, through to the major differences that occur and the costs that are incurred as a consequence of the sort of shifting people round into different roles and all that kind of thing. It also takes a huge amount of time away from the main business of patient and social care, because people get diverted into all the business of sorting out where they're going to be, what their next department will be, and all that kind of thing. The whole thing is enormously costly. It doesn't produce the results which the people, the architects of these major reorganisations always hope for. At best, you get bits of incremental improvement in bits of the system. But you do not get the massive improvements that are required to fix the kinds of things that Hilary was talking about a moment ago. In order to do that, we need to come away from the idea, which of course is ever so appealing if you're a politician, which is that there is a simple answer to this complex problem. Daniel Kahneman, the Nobel Prize-winning psychologist, economist, talks about the difference between fast thinking and slow thinking. Now, my years spent in Whitehall and Westminster working with government tells me that the simple solutions, the fast thinking, get to a simple answer to a complex problem as quickly as possible. That's what people want. Or at least that's what the policymakers would like us to be able to provide. But of course, it's self-evidently the case that at the very least, in Daniel Kahneman's words, we need to do a bit of slow thinking, working out what the nature of the problem is, and then fixing it, usually bit by bit. So no wholesale reorganisation, please. The second thing I want to say is that in order to do that, and in order to fix some of the problems, it won't work for all of them, but fix some of the problems that Hilary highlighted, we will need to build from the ground up, not from the top down. And what that actually means is working closely with people who are on the front line, the people who are delivering care on a daily basis in primary care, in acute care, and in social care. What are their experiences of working in those environments? And more importantly, perhaps, what do they know? What's their knowledge base? Because funnily enough, people like Geoff, who've been working in the system for 30 years, know quite a lot about the system. They certainly know a great deal more than a young fast-stream civil servant straight out of university does. But who sets the policy agenda? It tends to come through that fast stream business. Are there still fast stream civil servants? Anyway, you know who I mean. Many produced by this illustrious university itself. Now, it's not the good intention that's the problem. The fact is it's the absence of knowledge, an absence of ground-based knowledge of what it's really like, day after day, week after week, in some cases hours after hours. And I don't necessarily mean, well, therefore we need to consult with the Royal Colleges. We therefore need to consult with the BMA. Of course we do. But we also need to talk to the administrators, the receptionists, the people who on a daily basis are bringing the patients through, bringing the users through the system. And building from the ground up involves building from each of those sorts of constituencies in order to do it. Now, it's also quite important, I think, to note that there won't be a single ground-up solution. Because if you imagine that improving child paediatric care or neonatal intensive care or palliative and end-of-life care need the same solutions, you're clearly very misguided. In each of those specialities, there will be unique and special things that are required to be done in order to improve things. And that's where the starting point should be. So we must learn from frontline staff of all kinds across the system and across the service in all the different branches, the way the system is organised. The next thing I want to say is that we actually know a lot already about how to do these things. There is, in fact, an enormous evidence base. Now, you might expect, yes, and I will plug NICE. I was Director of Public Health at NICE for 10 years, and we produce guidelines on the prevention of disease, the prevention both of communicable and non-communicable disease across a range of conditions and a range of diseases. Now, if you go to the NICE website, you can type in obesity or diabetes or child mental health and well-being, and you will find all the evidence that was corralled together, all of the proceedings of the people who looked at that evidence and tried to work out what it told them, along with a set of recommendations. It's all there. The great failure, particularly of the last 14 years, but not only in the last 14 years, has been a failure to use that which we know, including the guidelines and evidence accumulated by NICE. But not only NICE, all of the other sorts of arenas which produce data and evidence. One of my favourites, and it's an anecdote that I've recounted many times, but in the years I was working in Whitehall and Westminster, there would be a moment soon after a new Secretary of State came into office in the Department of Health. And they'd work out that many of the preventable, non-communicable diseases at least, could be prevented. Yes, now smoking-related diseases. Yeah, smoking, that's a behaviour, isn't it? Obesity. Well, that comes from people eating too much, not taking enough exercise. Well, not taking enough exercise and eating too much, they're both behaviours. What about the problems we've got with alcohol misuse? Well, that's a behaviour too, isn't it? And then the light bulb moment. What we've got to do is change behaviour. But then the resort is to the simple answer to the complex problem. What we've got to do is get the messaging right. Get the message across. Tell people what they should be doing. To paraphrase, or not perhaps paraphrase, in the way that, is it the last but one Secretary of State during the pandemic decided the best thing we could do to get the population to do what they were told was to scare the pants off them. Now, surprisingly enough, that's not what the evidence says. The evidence base in health-related behaviour change is actually extensive, and some of the most important global evidence is put together here in Cambridge. Was that the evidence which was used during the pandemic? Oh no. Was that the evidence that's used every time a Secretary of State gets the idea that if we could only change people's behaviour, all would be well? So let's use what we know, including, if we want to change people's behaviour, the science of health-related behaviour change. Similarly, and we'll come on to this, I think, a bit later on, the problem of health inequalities, this massive problem, the wicked problem of health inequalities, and its worsening over the last decade or so is not amenable, as you might expect, as you'd not be surprised to hear me say, to simple and easy solutions. But there is an evidence base, and it's there if you choose to go and see it. Last couple of things I want to say, you're probably relieved to hear, is that one of the most important shifts in culture that we must endeavour to promote as far as possible is to rebuild trust. When I heard the current Secretary of State refer to registrars in the National Health Service as doctors in training, as part of the dispute, over money, I know she knows that that's not really the case, unless she's referring to the fact that all professionals should engage in programs of continuous professional development. But I don't think that's what she meant. That's not the way to build trust with professional colleagues. To criticise them, to tell them that they're not working hard enough, to say, and this worries me about what I've seen from some, perhaps across the political spectrum, more productivity. You go into a hospital and see how they're idling away their time. No, more productivity is, that sounds like an answer, but one has to be very, very careful because it isn't received well. It doesn't, in the current usage, land well with people who are stretched and who are under-resourced and doing the best that they can. Interestingly, while we have, and Hilary documented this at the beginning, the list of problems, the list of difficulties, at the same time, I must say to you, all is not bad. I was admitted to the Royal Infirmary in Edinburgh last October. I got pneumonia. And my word, pneumonia, that's an interesting one. When I was a little boy, old people died of pneumonia. Well, I'm over 70 now, and I can see why. But I was admitted to the hospital. I was in acute pain and distress. I could barely breathe. But within about 5 hours, I'd been scanned and x-rayed, and I was on a tsunami of intravenous antibiotics. I was in hospital about 10 days. Now, I could not fault the care that I received on that occasion. It really was good. And it's interesting, because we can be sort of deceived by the litany of problems. And I'm not saying they're not real. They're real, sure enough. But the years I worked at NICE, the chief executive was a man called Andrew Dillon, Sir Andrew Dillon. And I remember him once patiently trying to explain to a Secretary of State that the reason the NHS worked as well as it does was not because of political directives, was not because of plans dreamt up in Richmond House in Whitehall, but it was because the people who worked there every day made it work. It was their belief in trying to do the best that they could for their patients and sometimes the fallout from their relatives. And if we lose sight of that by constantly criticising the doctors, the nurses, the GPs and the rest, that will not build the trust that's needed to do it. On that note, Hilary, I'll stop and we can move on.
Great, thank you very much. And I'll now ask Thara to speak. Thank you very much.
Okay, thank you. I'm delighted to be here. I'm less delighted that we're having to talk about fixing the health and social care system. This needs to be something that we can rely on, not needing to fix. I'm going to take up where Mike left off, which was what it's a small glimpse into what it's like on the interface of health and social care. So I start every morning with a system pressures call. It's a multi-agency call. We have the hospital, primary care, the local authorities, the mental health trust, and we run through the numbers. So the numbers are how many people are in A&E, how many patients are waiting for a bed, and how many patients are on the corridor. We also talk about the proportion of people who have no criteria to reside. Now that's a government term, And it means that they're patients who don't meet the criteria for clinical care, inpatient care. And that's quite often about 20% or more of our bed base. And that has huge implications because it could then encroach on the number of beds we have for elective patients. So you can see that the pressures need to be addressed. I think these are, we talk about the OPAL status as well at that meeting. So OPAL 4 is the highest category you can get as a hospital. And it's when it's deemed that a hospital can't deliver comprehensive health care and there is a risk to patient care as well. And that oscillation into OPAL 3 and OPAL 4 often results in meetings being cancelled. And those meetings are the ones where you discuss innovation and that the transformation projects that will help to improve the interface between health and social care. I think, we have some really good, as Mike said, we have some really good systems in place. We have things, you've probably heard of them, step up, step down care. So an example of step up care is when you have a fall, we have, potential respiratory conditions. There is a dedicated team called the ICAT team, Care at Home team, and they will go out if you're in your own home or in a residential care home to provide that wraparound support. We have intermediate care beds to provide patients with 24-hour nursing care under a supervision of a GP. This is all to prevent people from ending up in acute care because that isn't the right place for them. We have step-down care, so patients who actually don't need critical acute care in a hospital, but they might need some supervision before they go back to their own home or back to their residential care home. They're called transitional beds. But there's never a stem of the people who are coming into the hospital. The demand is really acute to the acute hospital. We have some really helpful short-term funded projects. We have somebody called a high-intensity care user service. Now that we identify the people who come into A&E regularly, the frequent attendees, and we offer them one-to-one support over a 12-week period to try and get to the bottom of what it is that brings them into A&E as a first line of call. And the workers work with, say, it's not his real name, but John, a 47-year-old with repeated attempts at suicide and substance misuse issues. So John, by working with John, Rob was able to connect him in with some volunteering groups, and he is now a volunteer and has a sense of purpose. We'll call her Thara, 47-year-old woman with bipolar disorder, repeated incidences of financial and sexual exploitation. So by connecting Thara in with some community groups that she felt comfortable with, she's formed some friendships. Now, both of those people haven't presented to A&E for over 12 months. There are numerous cases where actually that high-intensity user service has prevented readmission, that repeated attendances by about 64%. These, unfortunately, are short-term projects funded by the Integrated Care Board. And when the money runs out, that's where it gets problematic. We had a worker, for example, on one of our wards who would connect people up prior to discharge with community support. But as soon as the funding went, so did the project. There is a fallacy that there is lots of money sloshing around in the NHS. There just simply isn't. It relies on short-term funded projects, but this is not something that we can do short-term. It's just not. It needs a better fix, mainly because we have a growing ageing population, which Hilary mentioned at the beginning. If you've read the Chief Medical Officer's report, his latest annual report talks about health in an ageing society. This is really, really essential. This is something we need to absolutely pay attention to. We've got people, and housing is absolutely critical to this. We have, in households where there are people who are headed by 75 years and older, they are disproportionately represented in those people who are living in non-decent homes. And that costs the NHS about 4.1 billion pounds, which is 1.4 billion pounds, which is enormous. And that's treatment costs to pick up on, the excess with cold and falls. For households headed up by somebody who's 55 and over, living in poor housing, that cost the NHS in treatment costs for 1 year alone about £513 million. And that's to pick up the effects of falls, as well as things like living in poor housing, which is poorly ventilated, poor insulation and poor heating. And that results in quite a lot of conditions, respiratory conditions, high blood pressure and psychological disorders. So these are things that we know that there are answers for. We don't need to keep continuing to avoid the question. So I do think we need to pay attention. We've known for many years that we've got a growing ageing population. We need to pay attention to those recommendations that Chris Whitty has made recently, and we need to do a number of things, which include making sure that we're directing the resources to the places that need it most. So we've got people in our rural and coastal communities. So are they fit for purpose? We need to be adapting the housing and transport options in those areas, as well as everywhere else. We need to be investing in primary prevention. We've got a huge amount of resource to do that. We need to improve our transport. We've got to, as Mike said, help to reduce obesity. We've got to improve conditions so that people don't have to smoke, and we have to do a lot more about improving air quality. These are things that national and local government have a significant role to play, but so do communities. We need to be doing more on secondary prevention. If we can stop people, the longer you live with hypertension and high cholesterol, the more likely it is that you'll have a disability quicker. So these are things that we can actually, they're largely preventable conditions. We can actually invest in that. We haven't always got the right data. So that's the fourth recommendation. Often we don't know for our older people whether they've got hearing loss or whether they've got mental health conditions. We simply haven't got the right data. So there are challenges for us on that. And then the last recommendation is about the research. So NICE, when I worked at NICE with Mike, we changed our name at the time to include CARE. It was NICE, and we included CARE, the silent C. The NIHR, the National Institute for Health and Research, has also included CARE, and we need to be investing more in social care research. There is some fantastic guidance around social care, just not enough resource and not enough time to use it. Cambridge University, Mike and his colleagues did a fantastic report on health, levelling up health. Some really, really practical recommendations that we can take forward around multi-sectoral working, around making sure that we're directing the resources at the right places and supporting our disadvantaged communities These are not rocket science, and we need to do more, but we need to do it quickly. Thank you.
Great, thank you very much indeed. And now we'll come on to our third speaker, Geoff.
Great. I hope it's all well. Yes, so thank you very much for inviting me to speak here. It's been a very, very long time since I was last in this chamber, probably a good 3 decades, so I never imagined I'd be sitting here, more where you guys all are. Right, so very much like Mike had said, I've worked for a number of years in the NHS. I still do, very, very part-time now, so I'm part of the NHS workforce problem. But also I've been a researcher for 20 plus years as well, and so this is a sort of fusion really of being a clinical academic, relatively rare in general practice. So being a regulated professional, so these are my personal opinions and also not any of my employers, and I definitely have no conflicts of interest to declare, apart from the fact I work in the NHS, so they actually pay for me. I'm definitely not an expert in this field, but perhaps drawing together this sort of fusion of observations of the research projects I've worked on and the years that I ran a practice for almost 20 years in Hampstead in London. Right. So I'm going to cover sort of 3 areas, and I want you to bear with me. It's going to prod you a bit to think about things maybe that are just slightly uncomfortable, but probably something which certainly when I ran the practice, we were constantly scratching our heads about and thinking, why does nobody talk about this? Right, so the first thing goes back to Mike's point, which is the NHS, this thing, it's a beast. Apart from the fact there are 4 nations, and each it's slightly different in the 4 nations, so, got to shout out for that. Things in Scotland run very, very differently to what happens in England, and we've been quite England-centric at the moment. So I cannot pretend to know what goes on in Scotland, although the impression here from us English GPs is it's way better up there. But obviously it's way better in Australia because everyone's going there instead. But the NHS, it's very complex, and there's some really important things about complexity, which I'll come on to next. Then I'm going to talk about some elephants, right? And I know you said this is to fix the NHS, not London Zoo or any other local zoo. But there's some really important elephants in the room that we need to talk about. And then we'll talk about possible ways forward. And I'm also going to, maybe you could say, cop out and use what Mike had suggested, which are principles. And the reason why I want to use principles is because there's no one-size-fits-all solution for our problems. If there were, we would have solved them by now, right? Nobody wants to create any of these problems and not solve them. Right, so, please excuse me, I have to look at this laptop. Try not to print anything out. Right, so the nature of the NHS is a complex system, right? So we've got to step back. Why does it matter that we're looking at this kind of monster thing, right? So it's a complex system. Complex systems have properties, right? And I know it's a bit of a contested term, depends who you talk to, etc. There's whole sort of different science fields and science and traditions about complexity. But let's just keep it basic. So there's lots of parts to it. We've already had comments about their social care, which intimately links to health. Then there's different bits of the health system. There are different people that work within this health system. Most of it depends on people delivering stuff, literally having to follow rules and or regulations and or bending them deliberately because they're trying to be patient-centered. Yeah. And then there's constant change. We have the massive reorganizations, but it's not just the massive reorganizations. At local levels, everybody is constantly trying to change things. Yeah? And so you effectively have this thing where there's lots of moving parts that interact in completely non-linear ways and often in highly unpredictable ways as well. So this is the thing we're trying to change. So let's also bear that in mind, right? And the worst thing about complex systems is they have these horrible feedback loops, right? So you do something here and you think, oh, I've solved that. And then it sort of feeds back and you get an unintended consequence of some description. You can kind of almost be certain that whatever you do, there will be an unintended consequence. Now, whether or not one thinks about that in the changes that we recommend, who knows? But we should really be very aware that there are potential unintended consequences. There are always going to be losers and winners as well, which is quite sad to some extent. But again, we need to think about that. Right. So, elephant number one, demand and supply, right? So when you run a GP practice, you basically get a fixed amount of money, right? There's a super complicated Cahill formula. There's different kinds of ways you can get additional funding, but it's pretty fixed. So we don't think that there is an infinite money pot anywhere. There definitely are efficiency savings, because ultimately, to be perfectly honest, whatever you don't spend, you take in as your drawings, right? So that's basically how much money you make. So very efficient, actually. But there's no infinite money pot. And this is a microcosm of the problem that the NHS has faced since in its way, its inception. Yeah? I mean, apocryphally, I don't know how true this is, the health secretaries used to think, well, eventually the demand will flatten off as we've cured all illnesses. There'll be no sick people anymore. So why would we need to be spending vast amounts of money on the health service? It's all done, right? And this whole demand issue, just to give you two simple examples, I still remember this as a child. First of all, prescription charges in England were introduced in 1952, and they've gone up ever since. Right? Now, the Scots, they've abolished it. I think it's free in Wales as well. For the life of me, I don't know what's happened in Northern Ireland. Please forgive me. Right? And then, of course, some of you probably had these, the old classic NHS specs. In fact, I still have a pair somewhere without any lenses in them. So I've kept it just as a memento. 1986. That's it. No more NHS specs for you. Right? So what's actually happened is the NHS has been trying to sort of secretly, perhaps, manage demand, perhaps behind your back without necessarily telling you. There's also been advances in medicine, and we've heard this from everybody. I mean, modern medicine is absolutely amazing. Let's not get this wrong. There are just amazing things that we can do. Just a very simple thing I still remember when I was a student, people would say, oh, well, back in the 70s, when you had a heart attack, that was it. Put you in a bed, give you some morphine, and we'll see what happens in the morning, right? Now, if you were in London, you'd be whisked off somewhere. People would be sticking catheters everywhere, and you'd be getting this sucked out or that opened up, etc. It's amazing. Yep. The consequence of that is we can treat more. I mean, healthcare is just a fantastic industry. It's a little bit like having a new iPhone every day. Right? There's a new medicine. Who read the front page of the FT this morning? Right? £4.4 million for a new treatment for a very rare condition. That's today. What will it be tomorrow? What will it be the day after that? £60 billion for treatment? Where will it stop, right? So this whole sort of threshold and whatever becomes a condition that's treatable is literally never ending. Yeah, it is literally the best industry on the planet. So we have this sort of problem. So what in the world do you do about this? Right? So a word you're not allowed to use, and I literally have been told off for doing this at CCG meetings, is the word rationing. Right? No one's allowed to use that word. It's a dirty word in the NHS. You can use healthcare prioritisation. Yeah. But you can't use rationing. But ultimately, that's what it is that we have to think about. This is just a little thing, slightly uncomfortable, get you to think about it. And it already happens. This is the irony of it all. It is happening behind our backs, right? So there's things like waiting lists. That is a form of rationing, right? There's things like local formularies. So depending on where you live geographically, there are certain things you can't have, right? And then there's also this thing called the procedures of lower clinical effectiveness. You can't have certain things. Varicose veins operations are one of them. Breast reduction surgery is another one. These are pretty much the sort of relatively low-hanging things that they can hang on with. But don't be deceived that that list doesn't grow and that list isn't a form of postcode lottery. It already happens. And the reality is, not even the Americans or the Swiss, who spend pretty much the most amount of their percentage of their GDP on healthcare, can afford to provide every medical treatment for everybody who needs it. Yeah. It is just not possible because everything advances and the need is I wouldn't say it's infinite, but it's pretty enormous. Yeah. Right. So we have to somehow manage this. What are we going to do? Right. So I'm going to talk about another elephant. And this other elephant very nicely ties into sort of Mike and probably Hilary's experience. Perhaps they'll say I'm just, it's my fantasy. But the NHS is highly centralised. It's very much just a command and control model. Yeah? Power is held centrally. There's lots of diktats that come out if you're working in primary care. It'll be like, oh my gosh, they've got this new thing they want us to do now. So an example would be access is a super important priority at the moment. It's super, super, super important. Right? Will you all do something about access? And I'm told by many of my colleagues who work in the CCG in a informal basis, nobody tells this in minutes, that they're constantly looking upwards and over their shoulder. Because someone's going to say to them, have you got an initiative to deal with access? Right? And your job's on the line, potentially, if you don't sort it out. Right? So that sort of command and control does cause a problem. Now this is going to be a bit of deja vu here, because either I'm psychic or Mike and I have actually knocked upon exactly the same thing. So try and make a change in a complex system using command and control. It's not easy, right? Because usually what happens is that it takes time and there's unintended consequences. We know that most politicians, well, they think about 5 years at the most, right? Maybe 10 if they're really lucky. So they want the change to happen yesterday. So what do they? Knee-jerk-wise, quick thinking, fast thinking, let's have a simple solution. And you can almost certainly see it sometimes when these things come out. I can see my colleagues' eyes roll and go, here we go again. Right? So it's the simple solution for a complex problem with potentially masses of unintended consequences. I'll give you a really quick example. Some of you, when you go to GP practice, may have noticed there are now a plethora of people. So certainly when I started, there was a practice nurse, and that was about it. In fact, when I started, there wasn't a practice nurse in the practice. But anyway, so there's now paramedics, there's a first contact physio, there might be a pharmacist, there might be a physician associates, that sort of thing. So it's great. That increases access, for sure. What's the unintended consequences? My GP colleagues are saying, well, who supervises these people? Who keeps them, who actually gives them any training? Do they have any training? Is the funding long-term? What am I going to do about this individual when they come around to me? In fact, I don't have the time that there's a long queue of people out there saying, what should we do with Mrs. Jones? What should we do with Mr. Jones? What should we do with Mr. whatever it is? Yeah. So there's an unintended consequence when you have this sort of knee-jerk. Well, there's not enough people, so let's just put more people. Right. Almost there, almost there. So why do we have to talk about these elephants? Because if we don't talk about them, we will literally be having this conversation 10, 20, 30, 40, 50 years from now. Because they were probably talking about this back in 1952 when they thought, ooh, you better introduce a prescription charge. But didn't quite say that this is a form of rationing. Let's call it something else. Yeah. It's uncomfortable. I'm not saying these are easy decisions, just saying, well, it's a problem we have to deal with. Right. So, got to have some solutions, right? It's not like, how could we fix the NHS and just go like, here's the problem, I'm off now. So, here's a couple of principles. I think they can be solved with political will. What we probably do need is to be a lot more transparent, and have sort of reasonable, transparent, coherent processes to decide what we should or should not be offering, and then when exceptions should be made. The last thing we need are very ad hoc, knee-jerk things that happen. Some of you may have heard about the breast cancer treatment, Herceptin. Yeah? So what happened with Herceptin? Brand new drug came out, shockingly expensive at the time. It's quite old, so it's probably relatively cheap now. It's probably off patent. And then suddenly we had this special pathway that you could go and have it. Yeah? Really? How did that happen? That has unintended consequences. You're going to be spending money down there on that medication, on those services. What about any other types of cancers if it wasn't a breast cancer? That's a choice, right? But we have no idea neither what the process were or what the values were that drove that. Yeah? Or in fact, even worse, what the ideologies were that drove that. Right. Are there solutions? I mean, people have tried this. I'm not in any way pretending that this is a solution. So people have tried different types of deliberative democracy. This is this idea that for a democratic decision to be legitimate, authentic deliberation must have occurred. Right? So things like citizens' juries are an example. Now, they sometimes end up with quite unintended consequences when you run these things. But there are ways that our voices, the fix, is actually us. I would say the block is whether anybody trusts us, as in you, the public, myself as a member of the public, or as a healthcare professional, or a social care professional at that, to actually have any power to make these changes? Or is it going to be command and control forever? Because we will then be back here in 20, 30 years from now, exactly the same problem. And it will take time, and patience is needed. So that's potentially a problem as well, right? And what we definitely need to do is to avoid the simplistic solutions, so my colleagues don't roll their eyes again and go, oh, God, not again. Right. So in summary, we've always struggled with sort of supply and demand problems. We never really talked about it. Yep. The healthcare system has actually constantly been rationing, completely behind your back, right? Whether politicians have the will and the willingness to share the power with us to allow us to address these issues is a slightly different question as well, because that's probably the only way forward. We as a society need to decide what we value, and we need to have a transparent and coherent process for doing so, because otherwise it'll end up being sort of, little pressure groups doing this or lobby groups, etc. Yeah? And we need patience. It's going to take time. It's going to take years and years of investment. As Mike says, we have the evidence. We just know that some of these behavioral change type things, for example, take ages. How many times does it take to stop smoking? Depending on how you count that, 7 to a few hundred times. Yep. So it takes time. And unless we understand that that's the problem, we're never going to get anywhere to fix anything. Right. I think what you're meant to say is I beg to propose or whatever it is at the end of these things, but that's not a thing. Thank you very much.
Yeah. Thank you very much, Geoff, and I can see some very consistent messages coming out. So now I'd like to hand over to Emily.
Thank you. Thank you so much for having me this evening to talk about this vital topic. So I'm here because I'm a former carer, as Hilary said when she introduced me. And I wonder what people think that means when they heard that. A lot of people think that means I was a paid care worker. I suspect the demographic in the room might mean you don't think that, but a lot of people do, particularly if they're 50 or under. If I was a paid care worker, I would be in the absolute minority of how care actually happens in the UK. I was actually the primary carer for my mother through her years of having 3 types of cancer and into her end-of-life care in her home in 2020. Carers like me, who are unpaid family carers, are the absolute backbone of how care actually occurs in society. It's not performed by social care. In fact, we outstrip paid care workers by 3 to 1. Okay? There are vastly more of us. According to the census, and most people think this is probably an underestimate because some people don't self-identify as carers, there are about 5 million, at least we can say, unpaid family carers in the UK today. If you consider that there are about 430,000 people in care homes, you can see that the number of people being cared for by family members in the community is just like exponentially more than people being cared for in care homes. We are the people who, when someone leaves the hospital or the GP surgery or when the palliative team leaves your house, we are the people doing the physio, dispensing the medication, checking the temperatures, changing feeding tubes, changing wound care. We are the care backbone of the UK, and we are largely invisible. When we talk about care, I do quite a lot of talks and panels, and frequently people will introduce me, not tonight because I know that Hilary knows this very, very well, but will introduce me and use the words adult social care or something like that. Aside from the fact that there's lots of disabled children who require care, and adult social care for some reason erases that, it also completely fails to take into account the lived reality of care in our society. Now, carers in the UK today are in an absolutely dire situation, and I'm not going to go into this at length because of time, but I will tell you that I have real people in my mind when I'm talking about this, people I continue to meet, people who are in just the most extreme suffering because we don't have any of the rights and resources we need. We don't have any respect for care in the UK. Carers, just some simple facts that elucidate it, are more likely to use food banks than non-carers, right? Because being a carer reduces your income, so you're more likely to be in poverty. Carers have worse mental health than non-carers, higher rates of depression and anxiety. They have higher rates of certain illnesses, heart disease, diabetes. They have higher mortality rates than non-carers. Suicidalism is, unfortunately, really prevalent amongst carers, as you will find out if you talk to carer support services, or unfortunately, if you've been in the position yourself. So it's dire. But here is the real problem, and why I think we need to think differently about the future of care, the future of social care. People's usual response, a kind of media politician-y response to this thing that I'm laying out for you, is, well, the solution is more social care, right? More paid care workers will reduce the number of family carers, therefore reducing the suffering that I'm describing. Social care is absolutely vital, okay? I'm not sure we do need more research on social care. I think we just need more funding. It's just absolutely woeful. And I'm in touch with carers every day, every week, who are on their knees, you know, being sleep tortured, desperate for respite, desperate for support. But social care, no matter how we arrange it, will always be only necessary but insufficient. And there are 4 reasons why. And these reasons, I think you only know them if you've been in the trenches of care, if you actually have lived the bodily reality, right? Firstly, the unwell, impaired elderly body is frequently very unpredictable. So if you've dealt with this, you know what I'm talking about. There are falls, there are infections, there are medication changes, lots of things happen all the time. A planned system is important, but it can never create a situation where you, as the loved one, do not have to step into the breach sometimes. Currently, we have none of the rights we need to enable us to do that. Secondly, people who need care are people, just like everybody here. And so they have a right, you know, if we afford them the dignity of choice, to decide who should be allowed to look after them. And what you'll find is, if you speak to lots of family carers, part of the reason people are doing it is because the loved one has refused outside paid care support. This is, I would suggest it's about 2/3 of family carers. That's part of the reason why they're caring, or why they're doing the intensity of care that they're doing. I found a great study when I was researching my book. I mean, I knew this firsthand, and I knew this from speaking to lots of carers as well. But I found an amazing study where some academics had gone and tried to find out why neighbours were stepping in to look after elderly, frail people. It was great that they were, I should say. I think that's wonderful. But they were like, what's actually going on there? They found that some of the elderly people had certainly been assessed by social services and asked whether they would like paid care support. And some of them had bald lied because they did not want to be tarred as vulnerable and needy, right? Who does? We live in a society driven by a kind of capitalist ideal of independence, as if we're all like gods in some way. Nobody wants to be seen as vulnerable and needy, even though that is obviously a fundamental part of the human condition. So we need to think about people's preferences for care. The third reason why social care can always only be necessary but insufficient is that carers are also the advocates and project managers of those paid services, especially if people have neurological issues or can't speak, they're non-verbal. So one of the interviewees in the book is called Lena. She lives in Norway, and she has a son with very high needs Down syndrome. And she has so much free support. It's incredible. It's what we should be aiming for with our social care system. But she said to me, she's very funny, she said to me, Emily, don't you dare tell people in the UK that everything's good here in Norway. She knows what we think about Scandinavia, right? She said, you need a first-class degree to access any of that support. So the old problems of access, navigating a bureaucracy, and I'm sure some of you will be thinking there's obviously going to be class, culture, migration issues in there as well. The fourth reason why social care can only ever be insufficient is that we love people. And I find it insane that I have to remind people of this. But part of the reason that we spend time with our loved ones providing them their care, providing what one of the people I know calls being their possibility makers, doing that washing and changing and temperature taking, is because we love them. And if you love someone who's suffering, and you're not some kind of insane psychopath, You will want to be with them some of the time, at least, and currently you have none of the rights, resources, or support to do that without great detriment to yourself. So we have to build the future of care, all care, from the empirical reality that's going on. And I'm so glad I get to be in spaces like this to kind of bring that lived reality to you. It does mean that we need some macro political changes, and I refuse to be cowed by the failure of courage of current governments and opposition, but to continue imagining that we will organise and build a better future. Some of those changes that we need, and I do think we'll win, include a shorter working week. If you assume that you're going to need to be doing care, then we have to reduce working time, right? We have to rebalance work and care, and that has to be legislative. Making it voluntary just means a load of white middle-class knowledge workers are going to have a great time, and everyone cleaning our offices and cleaning our hospitals is not. Secondly, we need paid, job-protected carers leave, so you can take time off and come back without going into poverty with your job protected. We have it for maternity leave, but we haven't caught up with caring needs, even though now we might be caring for people longer than we would have historically cared for children. We also need a real carer's income. Some of you may be aware that we have a benefit in the UK called carer's allowance. It's basically for people who are full-time, unpaid family carers. Do you know how much it is? It's £76.75 a week. And the carers I know who are in receipt of carer's allowance are profoundly offended by that. If you think about what they're doing to sustain life in someone they love, I am very bad at maths, but that is not a real hourly rate, right? These things I'm outlining run entirely contrary to the prevailing logic of our political economy, okay? Because what they say is care has value and legitimacy. It should be supported and paid. Our entire arrangement is geared to say the only thing that has value and legitimacy and should be paid is work that contributes to GDP, rather than what happens in the home, sustains humanity, rather than what I call materially resourced love. Some of you might recognise that I'm doing there the classic feminist argument between production and social reproduction. I could have been saying the same thing in the 1970s, and we have to move on from that. To finish, those were some big political changes, but I also truly believe there's things for all of us, personally, everyone on the panel, everyone in the room, to do as well in this regard. And I can sum it up as this. When I said at the start of my talk that there are about 5 million carers in the UK, I would bet that a lot of people felt a kind of subconscious relief because it's someone other than you. You are not part, perhaps, of that 5 million statistic, right? When we hear the phrase adult social care, it's a sector. It's separable to you unless you happen to work in it, right? I suggest to you, because of what I've outlined, that you're not a carer, you're a pre-carer. You will step into that 5 million at some point, as I did unexpectedly 5 or 6 years ago. And that's where I think we need to start the future of care from, is what would you need? What the hell would happen in your life if that was you? Because it will happen. And it's shifting that mindset to understand, hang on, I love people, they're in human bodies, and those bodies will break. Therefore, I'm going to be called upon, I'm going to be implicated in this vital human activity. And we need to start and build from there. Thank you.
Thank you very much. A very, very powerful account, which I think a lot of us can relate to. I have just had a signal that we need to move to the audience, but I'm just going to ask one question before we move to the audience, which I will put to everyone. And that's about technology. I mean, nobody particularly referred to technology and the potential for technology in changing how we deliver healthcare, how we deliver social care perhaps, or caregiving, and whether that, you know, might be a game changer, or how it could be a game changer. And thinking of technology in the widest possible sense to include AI, you know, how can that help us move forward in these different types of health and care settings? And I'm going to ask Emily to talk about that first. I mean, think of technology. We have these images of robot carers, of people in one part of the country having some kind of surveillance system so that they can see, you know, if someone's left the grill on or whatever in another part of the country. You know, what do you feel the power of technology is or isn't?
Thank you. Yeah. I mean, technology is a huge bucket, right? And actually, technology has always been used in care. Like Victorians ringing a bell for help, you know, technology's always been there. And there are different types of technology when you're a carer that are relevant. So things that assist you with stuff like moving someone or feeding someone, things that monitor that person's temperature, blood pressure, whatever. And also now, things that provide companionship. So I had the strange amusement through my research of meeting one of the AI-driven social robots being beta tested in New York for use with elderly people. So you would have this little guy, looks like a Pixar character, who would chat to you, and it's not like Alexa, it's not command controlled. It actually learns what you like and will provoke conversation. The woman who was testing it loved it, but here is the thing. She loved it because she was very lonely, and she was very frustrated because she used to have a care worker who she really liked. But the care worker's company kept docking the care worker's pay because the bosses kept being late, so she was checking in late. So that care worker had to leave and go somewhere else. And this, for me, is the point about technology. I'm very suspicious of people, especially tech bros that think an app will solve everything. Well, that's another problem. I'm very suspicious of people that think technology is the answer because they tend not to be looking at why the question's being posed in the first place. In that instance, it was a workers' rights issue. In another instance, I found a couple of sisters in Germany had a mother who was bedbound with MS, very elderly mother, and so they'd rigged up a camera so they could watch her while they're at work in case she got distressed, and then they worked nearby so they could pop round if she did. Fine, maybe, but that relied on them having an employer who, through their goodwill, allowed them to leave. Otherwise, what kind of torture would that be? You're just watching your mum suffer on a tiny camera, right? So we have to still think about this wider thing. And I think part of the reason that tech is being touted as the solution to care is obviously governments want to reduce costs. They think if they pump a load of investment in now, over time they'll reduce costs. And the whole conversation becomes about how do we design this ethically? Like, how do you make it actual care? I don't think we can. I give the example in the book of washing my mum. And that when I was washing her, I wasn't just cleaning her, soap, water, drying. I was also talking to her, right? Distracting her from what she felt was shameful, getting her to rant about how crap the government was, which was her favourite thing, which meant that she would then be more likely in an hour's time to take the fluids that she had to take and hated taking, which meant I could keep her out of hospital for another few days, right? So it's a whole layered process. So I don't think we can design it in a way that replaces human care. But I also, just to finish, think the reason why we're even having that conversation is because of a political foreclosure in which we will not discuss the things that I've just talked about. Why do we not reduce the working week so that we can free up time without a loss in pay for people to provide care? For example, Japan is one of the countries that is really obsessed with care robots. It has the most in the world. It also has some of the most restrictive immigration regime in the world. Guess what? They have hardly any staff, migrant staff in their caring and health professions, right? So we have to ask, what is going on that's making that seem like the necessary solution, rather than getting into all this detail about what that could look like? Thanks.
Great, thank you. Geoff? Geoff or Thara, and any thoughts on technology and how that could be transformational? Or not?
Well, I think I would definitely concur with Emily here, which is, what is it the solution for, as opposed to, because I think what we're getting quite a lot of is a push. I've got this thing, use it, use it, use it, versus what are you trying to solve with this thing? That's number one. Definitely not move fast and break things. How about move slowly and be careful and check out what the unintended consequences are? So definitely not one for the tech bros. I think that there's definitely certainly from some of my colleagues who worked with industry, they don't understand why you need to do research. Why can't we just do stuff, right? Because it might harm people, right? Would be one thing. We're talking here about healthcare. We're not talking about, I don't know, using my phone. Actually, that probably might still harm me. I might get neck ache or whatever. But we're talking here about healthcare, or in this case, social care. So technology has a place, but it has to be carefully evaluated, and it has to almost certainly have to be fit for its purpose and have a very clear purpose, as opposed to, well, that's just technology for everything. I'm sure some of you love the technology that's been introduced, like e-consult, where you're forced to have to get in touch with your GP via some sort of interface. Do you all love it? Yeah, loads of people do, some people don't. It was just foisted on you, right? Did you have a choice? Not really. That's the problem.
It's not a substitute for decent care and support.
I mean, just, is there anything positive? I mean, I've heard, I think it was Wes Streeting talking about new scanners that could identify and move forward diagnosis of someone who's had a stroke, sort of get them moved through the system more effectively with better outcomes. I mean, are there instances in which technology, you're seeing it, being in any way transformational?
Of course. But there is the danger of it not getting to the right people. So, when you see who comes through the doors of the NHS and social care, it's people from the most underserved areas. And you've got the danger of increasing health inequalities by focusing on some of the digital solutions, which just don't work for a lot of people.
Yeah, okay. That's really helpful. Okay, so moving on now, and sorry, unless Mike, I mean, you're not on the front line, so I didn't ask, but if you've got any insights into technology? Okay, I'm sure there'll be questions directed at you.
I can barely use my phone.
Very shortly. Yeah. Okay, questions from the audience, and we've got roving mics. Okay, so right towards the door, the woman with her hand up. Thank you.
There we go, technology.
Yes.
Okay, can you hear me?
Yes.
Yep.
Okay, well, thank you very much for the talk. I just wanted to say, you said we need patience, but do we actually need patience? None of you have really mentioned the contribution that actually patience might make to the change. And I just wondered what your views were on what patients are able to contribute to the fixing of these, what seem to be impossible questions.
Okay, and shall we take one more from, there's someone very close to you, man on the front row, I think.
Yes, so I just want to ask really, why is it that other countries, similar countries in Europe, seem to be doing a lot better? And you may disagree with that. And what can we learn from them, maybe?
Great. Okay, I'm going to put those two questions to Mike. What can we learn from patients, and what can we learn from other countries?
Okay, well, on the patient thing, I didn't mean to exclude patients when I was talking about building from the bottom up. The interface is not just the frontline staff, but it's also the patients in receipt of care. And quite interestingly, one of the columns in I think it was a BMJ, or perhaps it was the Lancet, which many of my medical colleagues used to read first, was doctors writing about their own experience of going into hospital and having treatment. And in fact, patient accounts is a big area of research, and we know a lot about there is all sorts of experience of particular conditions and diseases and treatments and so on. Now, what we've been less good at, I think, is corralling that knowledge, it's evidence actually, corralling that evidence and bringing it into the picture when we talk about the kinds of fixing things, but just in the way that the information of frontline staff is critical, so too that of patients. The idea of expert patients has been around a long time, actually. And I just... the last words I said to the consultant who diagnosed my pneumonia was, beware the expert patient, because I'd already offered them 3 different possible diagnoses of my condition on the basis of my last admission to that hospital some 3 years. I said, well, I had kidney stones last time I was here. And of course they checked. And in fact, what they checked while they were worrying about that was to see if I'd had an aortic aneurysm, which was the initial suspicion of this terrible pain that I had. No, patients are absolutely vital and important to this whole process. And what we need to beware of is a kind of rhetoric which says, well, we've got patient and public involvement, all this kind of thing. It has to be real, it has to be meaningful. And the kind of accounts there Emily was talking about, in her case about carers, is the sort of thing that can allow us to develop better and get to solutions more quickly. Also, quite interestingly, it's the sort of thing that politicians love. They like a good story. And if you've got a good story of experience, that sort of thing captures the imagination much better than a graph and p-values and that sort of thing. In terms of learning from other countries, I think one has to be cautious because there are, when one looks at the data across, say, Europe or Europe and North America, there clearly are things where other societies outperform the UK. But Geoff made an important point when he was talking about Switzerland and the US. Some societies spend a great deal more of their GDP on health and healthcare than we do in the UK. The real question, I suppose, one would want to ask is what's the best value for money in terms of what we're spending and what we're getting back? Because, as has been said, the demand is virtually infinite, but our ability to supply solutions, the resource to get to solutions, is obviously finite. And that the trade-off between the two is both a social and political matter, and different societies arrive at different conclusions about that.
Great, thank you. Anyone else want to add on patients or other countries?
We couldn't do what we do as a hospital, and every hospital absolutely relies on patients. We recruit a huge amount of volunteers as well. So that's the other sector that are absolutely vital. They often spot things that nobody else would spot in the hospital, and that they provide an absolutely valuable resource. So as a public health person, I talk about communities, but I mean patients as well.
I mean, just personally, living in this city with a major teaching hospital, I've been involved in umpteen studies on all sorts of things. Every time I go in for anything, they say, can we just include you in our research project? And I've even been an exhibit in a medical finals exam. And I was an exhibit. I was 8 months pregnant, so I was an exhibit as a pregnant woman. So yes, I'm on the sharp end of patient input. Emily.
On the patients question, which I'm going to think of as beneficiaries of care, there's a really interesting kind of new model exemplified by something called Equal Care Co-op. I'm not an expert on this. I usually try not to talk about it in case I say something wrong, but it's a very brilliant model whereby the person who requires care is seen as part of a team of the triad that makes up care: the care beneficiary, the family carer, and the paid care worker. And that person, assuming they're able, right, so neurologically, etc., able, is in charge of how that that team, they call it, operates for that person. And so I really like that as a different model. It's a co-op as well, and I think this is a crucial element of it. It's not a profit-making venture, which is what's happened to social care. The vast majority of social care now of care homes has moved into private hands and is being milked for profit that's then taken out of our community. So the Equal Care Co-op, they periodically do share issues, so I'm sure they will at some point, and I think they're an amazing model that I would like to see grow. Just on other countries, I'll mention, because it's quite a specific example of change that we could make that is kind of, it's interesting. One of the things that I know myself, but also hear as some of the most kind of heartbreaking stories in relation to care is people's absolute desperation for respite breaks, right? So, for example, I know a young woman at the moment who's the single mother of an autistic child who's got very high needs autism and who's getting about 3 hours sleep a night, and that's been going on for years. So we are really talking about a torture situation. And she would really, getting free respite care for just one night even, but, ideally more, is vital. Now, that's not forthcoming where she lives because of cuts to social care funding, so obviously there's a problem there. But even if there was that funding, a lot of people can't take up respite care because the personnel change so much, the paid care workers. So you can't be like, here's my mother with dementia, or here's my son with extremely complex autism, and just hand them over to a stranger that changes all the time. When I interviewed people from other countries where things are better, they had much more consistency of the paid care workers that were involved with their loved one. And that's because they don't have the absolute chicanery of agencies running their social care workforce, where there's this really high turnover, those workers are not respected, they're just like shunted around like a commodity. So I think we can actually look at those business models that might not sound like they're about care, but actually end up being about care.
Great. Okay, thanks. So I'm looking for some more questions. One here.
Working? I'll speak loud. It is working. Yeah. Thanks to everybody on the panel. I learned an awful lot from each of you. Superb. I'm wondering, I would like to give the panel and indeed everybody in the room what I call some killer statistics, and you'll see why. Michael Marmot, writing in The Guardian exactly 1 year ago, pointed out that if you calculate health spending per person adjusted for demographic change, so there's a proper real health spending per person, this grew at 2% a year under the Conservatives from 1979 to 1997, Thatcher and Major. It grew at 5.7% a year under Labour from 1997 to 2010. After austerity, from 2010 to 2015, it grew at minus 0.07%. In other words, if you properly adjust for our ageing population, we have been de-spending on healthcare per person in this population. And I'm afraid in 2015 to 2021, even despite the pandemic, it grew at minus 0.03%. So in other words, we've been actually de-spending on our healthcare, despite ministers announcing millions. They'll always tell you what they're spending in millions. They won't tell you what they're really spending in real terms in terms of the need of the nation. And I thought that this is terrible and what a disastrous problem. And then I heard something very interesting from Geoff Wong, who said, healthcare is the most profitable industry on the planet. And I began to wonder, are we all missing something? Is the NHS missing something? Are we actually allowing the funding to go too much into profits from exactly the same people who are providing our health and social care, benefiting from all the drugs and all the demand that's rising in our population? Should there be a real complete change of approach towards, it would have to be that evil word, the taxation of pharmaceuticals and healthcare industry companies on the grounds of the enormous profits they're making from all of our needs.
Okay, maybe Geoff, you'd like to pick that one up.
Well, that's a choice we can make. The politicians or countries can make that choice if they wish to. I suspect that there will be lots of pushback. There are very strong lobby groups. It's an asymmetric war. I mean, we spend vast amounts of money on NICE, but there are also large organizations that help pharmaceutical companies, for example, develop products, seek markets, market it, do predatorial type stuff. The Shrekley Award's a very good example. The chap who bought a very, very rare drug and then jacked up the price. It is what we decide and let it be. That is the challenge that we have. The problem is we don't know what drives the decisions behind this, or we can only have a vague idea about what drives the decision behind this, because it's not necessarily there isn't direct representation around this. That's partly the problem. So you can vote for a party or a politician or your local MP because they're fabulous, but you have no idea how they are going to influence, for example, or how they will respond to new lobbying for, trying to reduce the thresholds for when we might treat a new condition. And therefore, statin's a very good example. I mean, it's now 10%. Anyone can have one now, right? How did that end up being there? Right? How did the lobby groups get to that point that you can effectively be told, well, there isn't a threshold. If you want one, you can have one, because it'll benefit everybody. That's not quite true. The absolute benefits are not as massive as you think, depending on whether it's primary prevention or secondary prevention. But the rhetoric that we will get now is driven by these various lobby groups. We could stop that if we wanted to, but do we have the choice? Do we have the ability to do so? That's partly the problem. Who's given us the power? Who hangs on to that power?
Well, I'm going to see if Mike wants to say anything on this, because you work with select committees, you work in Parliament, you maybe have some insights into how these decisions get made, how they could be changed. I wonder, is it something that gets discussed or that you're aware of?
Oh, yes. So first off, one of the most important things we could do is ensure that with drug development, and interestingly, they don't call it drug development, they call it new technologies. So drugs are part of the new technology business. And NICE was set up originally, and I will dwell on this for just a couple of seconds, in order to ensure that new technologies, new drugs coming into the National Health Service were good value for money, in the sense that it's very easy for pharmaceutical companies to develop new products which are a little bit better than the existing products in the marketplace. And that's a very common model for drug development across the world, not just in the UK, but all the pharmaceutical companies worldwide. The problem arises if that little bit of better effectiveness is costing you 10 times as much as the product that's in existing use. And of course, there is an enormous lobbying that goes on the part of the companies to suggest that this is the latest miracle drug for X, Y, or Z conditions, when in fact, it is just a little bit better than what we're using at the moment. And what NICE was established to do was to determine whether those things that are a little bit better are worth the extra money they're going to cost. And of course, when NICE said no, as it frequently did, often all hell sort of broke loose, until ministers realised it was much better for NICE to take the flak than for ministers to take the flak. And so NICE was allowed to continue in this, being the awkward squad as it was. Of course, from time to time, a new technology, a new drug is a stepwise difference in terms of what it can achieve. And at that point, if you're getting a big stepwise difference, the cost is probably, on balance, going to be, or rather the cost effectiveness will be worth it. So that's the first thing. Now, in terms of the way politicians kind of receive this, and I often, on a number of occasions, I sat in front of select committees and said, look, this is the value for money for basic prevention of something like obesity. in children. Or this is the basic value for money, the cost effectiveness of doing this with respect to, say, alcohol misuse prevention. And you give the numbers to the MPs. And, for example, the typical cost per QALY of most public health interventions comes in at about £7,000. Now, that's not a real money, it's the way economists do the calculation. Whereas most drugs come in 35,000, 40,000. In the case of advanced cancer treatments, it's in hundreds or 200s or 300,000. So there's a quanta difference. And the MPs would kind of look at me and say, wow, that's kind of amazing. Why don't you do something about it? And I'd say, well, I have just done something about it. I've given you the evidence. Why don't you do something about it as the politicians? And of course, what then happens is that in the mix of things, the kind of belief or the notion that there is a quick pharmaceutical fix for anything, and it's about acute care rather than the kind of care that Emily's been talking about, or prevention more generally, that sort of thing gets pushed aside in favour of what looks like the kind of high-tech or usually pharmaceutical kind of solution. When David Cameron launched his big idea with respect to dementia, he assumed that the answer would be a new drug. Now, it's not to say drugs can't make a contribution, but it's to say if you can, we're certainly working with the vascular dementias, lifestyle things in your 20s, 30s and 40s is a much more cost-effective intervention than any potential drug in your 70s, 80s and 90s. So the dominant view that we've got a tech solution, and when we were talking about tech earlier on, I mean, that's what I would have said. If, you know, tech is not one thing, it's lots of different stuff. And some of these things are enormously beneficial, but not all of them. And what they need is exactly the same kind of careful evaluation in terms of their effectiveness and cost effectiveness, done through proper research, even though, as Geoff said, the companies often don't really, why? Don't we just do it? I've got this great thing for you. The careful protocols for evaluating of these sorts of things are there to be used. And as you get the pushback, whether it comes politically or industrially or from pressure groups, is something that we have to have the courage, actually, to resist and insist upon a proper evaluative set of protocols for all of these things.
That's really helpful. I'm just going to take, I haven't taken anything from this side. Was there one very quick question that we could have, that the man in the grey jacket up there?
Fiona Bruce, trying to identify the audience.
I know, yes, yeah.
Hi, thank you. Mike poo-pooed a bit about efficiencies in the NHS before, and I'll just give you a recent example. I had a friend who was in Ali Brooks on oncology, and for sake of calling it liquid food is what he was being fed. So they delivered this from Sheffield, and they had 3 lots. The date was given in the wrong order, so by the time the 3rd day came, he couldn't have that food. So they had to order him some more, and he had to go with no food for 24 hours. The food turns up the next day, no problem. The following day, the delivery arrives, and he doesn't get fed. When he asked where is it, nobody knew where it was in the hospital. So he waited another 24 hours without getting fed. So again, they got another delivery from Sheffield. Another example recently, I went for a flexible cystoscopy on Monday. I drove to Stevenage with my wife, because I couldn't drive afterwards. I got there, they said, you've been given the wrong appointment. Oh, okay. The consultant will see you anyway. So I saw the consultant, he said, everything okay? I said, yes, apart from I need a checkup. Yeah, you're wrong appointment. We'll have to make another appointment, leave it with me. There's just 2 examples in the last 3 months that I've seen.
Okay. And do you have a specific question, or are you?
No, I'm just saying
just
that
patient
Mike
feedback.
Not really want to be concerned about efficiencies. And,
okay.
I think sometimes it's busy fools in the NHS.
Okay. Okay. It was helpful to have that patient insight. I'm going to close now very shortly. I'm just going to ask each of the 4 panel members, and thank you very much for your insights and contributions. Can you identify one thing each in 20 to 30 seconds that is your top priority now for how things should change and what might make a difference? Thara, I'm going to ask you first.
I think it's, when people say how are we going to tackle the pressures in health and social care, it is about making sure that we are tackling health inequalities, really making significant improvements for the people who are most underserved. That is going to make a huge difference to our pressures. And people like Mama and others and Mike and colleagues have really helped in that space. We don't need to flounder about what to do. We know what to do. We just need to get on with doing it.
That's a really helpful final insight. Geoff?
One word would be workforce, right? It's a service industry. It relies on people. And people, surprisingly enough, are human. And if there's one thing that's been broken, I speak to some of my younger colleagues, I'm near the end of my career, they're starting in their careers. I think they feel betrayed. I think they feel that the social contract that they, have slogged their way through med school, sometimes with enormous debts, and they've been thrown to one side.
Okay.
And I think just the workforce thing, I think the workforce thing might answer that problem over there.
Yes.
Right?
Yeah.
It's a workforce problem.
Okay, thank you very much. That's also really helpful, Emily.
I had a feeling you might do this, and then I was like, what will I say? I'm going to go a bit left field, and I think I'm going to imagine a world in which I can ban all politicians from being able to access privately paid care for their loved ones, so that A, they are carers and give us the things we need as carers, and B, they're reliant on social care and they invest in it properly.
That's a really good idea. Mike?
I would like to see a shift toward prevention. We do not fund prevention enough. There are many highly effective ways of preventing disease. Not all disease, of course, but many conditions are preventable. And the effort that goes into fixing people up after those diseases are established is a much less cost-effective way of doing it than preventing it in the first place.
Fantastic. Really, really great final insights. And thank you for all of your wisdom and responses to questions and your initial presentation. It's been a great session. So one final round of applause. Yes.